Okay, so for legal co-management, the following principles should be followed. The patient has a written agreement. Patients are explicitly consenting to co-management in writing. There needs to be written transfer of care. There must be a documentation of transfer of care between the referring optometrist, then the ophthalmologist, then back to the referring optometrist. There needs to be, in the case of, just look at it just like your co-management fee. When you bill co-management, you're going to bill, the surgeon's going to bill for the surgical package. You're going to bill for the co-management package, and the surgeon's going to get paid from CMS or other payers for the surgical package. You are going to get paid for the co-management package. It is completely separate. You do the same thing on premium IOLs. There are separate fees. Each physician sets their own fees. I set my fees. I tell what the surgeon what those fees are. I collect my own fees, and the surgeon collects their own fees. Hello and welcome to the Crystal Podcast on iCode Media. Today, I'm not going to have any sponsors of this episode outside of iCode Education. We're going to talk about the important aspects of caring for our patients and not allowing another profession to control or dictate or scare us into abdicating our responsibility as the primary eye care profession for patients specifically related to co-management issues. So I'm going to talk about an issue that has come to light over the last few weeks. I can't tell you how many emails I've gotten related to this, and it seems to be stirred up by a couple mass emails from cataract surgeons who used to co-manage and who are no longer co-managing, and they're using optometrists' words and an economic argument for us to stop co-management. And really, when you think about the history, the underlying history with co-management, a lot of this stuff is bred from years and years and years ago within the American Academy of Ophthalmology, pushing and trying to scare their members into not co-managing. So I'm going to read a few letters, and I will keep the names in because these letters are public. So I'll keep the people who wrote the letters. I'll cite them. I'm happy to talk to those doctors. I actually don't think the doctors that I'm citing in these letters are bad actors per se. I have no idea of their intention. I just think they're misguided. I think their fears are misguided, and I'll talk about how to allay those fears. So in this episode, that's what we're going to do. I'll tell you that if you think about, I want to plant a couple seeds in the back of your mind when you think about the history of the profession and the history of co-management. I believe, and I think the American Optometric Association has been very strong in the belief that optometrists serve as the primary care provider for patients, all patients' eye care needs. Until or unless that patient has a problem that is outside of the scope of practice of optometry, the best place for that patient is in the optometrist's office. The other thing, when I think about co-management, is that it's not just about, it is obviously about taking care of that patient and getting that patient back to their primary eye care doctor, which is the optometrist. But it's also, in my opinion, about keeping the surgeon honest. So if we just abdicate all those responsibilities to a surgeon that we think is good, we don't know, that surgeon's not beholden to us for good postoperative outcomes until 3 months or longer, when that patient might come back to our practice, maybe. And the American Academy of Ophthalmology, I've got a lot of mentors in the profession. David Cockrell, Bob Vandervoort, my dad, Bob Lehman. I could just kind of go down the list of all these guys that have influenced me. George Foster influenced me over the years. And I think about the work that they've done to have parity within Medicare, to have access to patients. And then we have people who want to use economic arguments that this isn't worth it for us to give this type of care to patients is kind of astounding. And it's astounding to me that this argument is working on our profession. Now, please don't misunderstand. A lot of the things that I have done within iCode is to help doctors understand their value, but it's not primarily for us to understand our value. It's primarily for us to take care of the patient and know that if we take care of the patient, the value will come. So if I've ever made a misrepresentation of what we do here at iCode, I'm sorry, that's not what we do. My whole thrust and our whole thrust within all the people that work at iCode is to try to give patients the best care possible. That's the primary role. The reason we talk about economics so much is if we don't understand the economics behind what we're doing, then a lot of times it's harder for us to give the best care possible for patients. And so in any case, these economic arguments that I'm going to talk about are really troubling in my mind because they are solely economic, but they're under the guise, again, I don't think that it's malicious on the writers. I'm going to give them the benefit of the doubt. The authors of these articles, I don't think are malicious. I think they're being manipulated. I think they're being manipulated to think that it's an economic argument, but they're being manipulated by greater organizations who want to control access to optometry. And they're trying to get optometrists to abdicate that responsibility for the patient and not want access to the patient. So here's where it all starts. I got an email a few weeks back now. Actually, by the time you're listening to this, it's probably about a month back. And it just says, hey, Chris, take a look at this and give me some feedback. If you're unable to view the letter, please let me know. So the email comes out, and it's from your surgical team, Mark Mandel and Robin Kurioksi. I'm going to butcher his name. I'm sorry. These are cataract surgeons. And the email says federal oversight of co-management. And so it says, as you know, in response to specific requests by individual patients due to many factors, including geographic proximity or your familiarity with the patient and family, we've been co-managing cataracts for many years. Of late, co-management has come under intense scrutiny by the federal government, specifically CMS, which manages Medicare and Medi-Cal. They're increasingly conducting audits of both optometric and ophthalmic practices that participate in co-management of Medicare patients. This has come to our attention both from letters from CMS and from the attached letter from Stephen Faith OD, which we highly encourage everyone to read. This increased scrutiny by Medicare, which all but prohibits co-management, is unfortunate in that there are many patients who request and certainly benefit from co-management. However, CMS and their auditing team view co-management differently than does the requesting patient. As you know, many of the finest and most well-respected practices in the Bay Area, including Dr. David Chung, MD, Brian Lee, MD, Dan Goodman, MD, do not co-manage any cataract patients. As a result of the increased oversight by CMS, your safety and mine from government sanctions, fines into the millions of dollars, and possible prison will no longer be able to co-manage cataracts. We all know that this is often due to the detriment of the patient and hardship of their family, but we have to be careful of government intrusion into our practice of medicine. You have known our practice long enough to know that we will absolutely return patients to your care following a 90-day postoperative period for follow-up care and at 3 to 4 weeks for refraction and glasses as needed. We feel strongly that holding on to your patient after a 90-day period is neither professional or ethical. Additionally, you know our practice is unique in the Bay Area and that we are purely consultative and surgical practice. We do not see any routine patients for general eye exams, glasses, or contact lenses. Additionally, as you may or may not know, we are one of the only practices in the entire Bay Area that does not have an optical department. Accordingly, there can be no confusion from the patient's point of view as to where they will do their 90-day follow-up care and or where they will receive their spectacle correction. Although much lesser importance than our granting patient requests for co-management, we have never given much thought to the economics of co-management from an optometric point of view. When you read Steve Faith's letter below, it becomes obvious that it's actually economically burdensome for the community optometrists to see a patient within the 90-day postoperative period for co-management due to the exceptionally low reimbursement. Clearly, we do not co-manage for economic reasons, in that any optometrist can make considerably more money by simply seeing a routine office patient rather than receiving poor reimbursement from Medicare or visits during the 90-day postoperative period. When we co-manage solely in response to the patient's request, and accordingly, we concentrate on the patient and their personal, family, or medical needs as our primary focus. However, it's fascinating to the degree to which the economics of co-management make absolutely no sense. Again, something we have never considered. If there is highly unusual situation where the patient must co-manage, please feel free to call us by cell phone and we can arrange a very specific case of co-management. So, okay, I'll come back to that in a second. We look forward to continuing to work closely with you to ensure your patients receive the highest level of care and the latest technology for cataract or corneal surgery. Of course, we continue to co-manage refractive patients who request co-management, LASIK, ICLs, etc. Please read the letter below from Dr. Steve Faith, which we believe will be instructive and helpful in your practice. As always, call us by cell phone, etc. Yours sincerely, Mark and Robin. Then it says, click here to read Steve Faith's letter. I'll point out that they're willing to co-manage in very specific cases, but not in general cases, which means that they're willing to, if CMS is so concerned with cracking down on co-management, which they are not, by the way. They are not concerned with cracking down on co-management. What they are concerned about is cracking down on co-management where premium IOLs are involved, in which case the doctor who is performing the surgery is collecting all the fees and then splitting those fees or paying the referring doctor perceivably from that referral. Now, I'm going to talk about ways that this is legitimate, where you can do it, and it is legitimate for the surgeon, even by CMS, for legitimate for the surgeon. We've done this on the podcast before. Both I have and Dr. Joe Deloche through Aaron Warner's podcast have talked about surgical co-management of premium IOLs in a way that does not violate the Stark law. And we'll talk about that again here today, but CMS is not cracking down on co-management. They are cracking down on the Stark law, and that is sharing fees inappropriately between the surgeon and the optometrist. And I'll say this again, there are ways to inform the patient to disclose that relationship that allow that to be done. The idea that co-management cannot be done because CMS is cracking down on it is not accurate. So I want to make that clear. Now, we're going to get into Dr. Steve Faith's letter. And again, this is not a criticism of Mark or Robin, nor is it a criticism of the optometrist Steve Faith, but both have been used in this case, in my opinion. I think, giving them benefit of the doubt, they've both been used in this case to perpetuate the idea that co-management is, one, not kosher, which it is not. It is not kosher. It's completely kosher, but you have to do those things the correct way. And two, that it is not economically rewarding. So again, using economics as an argument against it. So in any case, you'll note that there is no other citation about CMS or Medicare cracking down on co-management related to the specifics of co-management. That was never cited in the letter that I just read you, the email that I just read you, nor is it cited in this letter that I'm going to read you from Dr. Mark Faith, who again I do not know. I'd love to have him on the podcast to talk to him, and if anybody knows him, please reach out to him and let him know. Again, this is not to disparage him. I think he is just a little bit misguided in the economics of co-management being the primary driver. I think the primary driver should be taking good care of the patient and delivering that patient back into our practices. And really, when you look at the economics of co-management, the time it takes to co-manage a patient post-operatively after cataract surgery, you'll actually get compensated more for that pure time than you would for almost every single other managed vision care plan that's available. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education, for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com.
We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com.
So in any case, I think that even the economic argument is sort of dubious, and we can do the math on that at a future episode. But the reality is that this is not an economic argument. It's an argument for the best interest of the patient in my mind. So in any case, this is a letter to the surgeon that Dr. Faith wrote. So it says, this past spring, I participated in the ABB-PEN's yearly billing and coding event. It's something that ABB-PEN has been sponsoring for mostly California ODs for over 20 years. Dr. John McGreal out of St. Louis is the headliner. He's an optometrist partner at an OD-OMD specialty practice with anterior segment, glaucoma, retinal specialties, and all in the same location. I've known John for over 25 years. He's an incredible speaker and an amazing wealth of knowledge on all subjects, ocular and systemic disease. He knows Tom Magarlis, who is at Washington University in St. Louis. A particular area of expertise for John is his billing and coding, specifically his CMS Medicare knowledge. He's an expert witness and consultant in many insurance companies, payer, and doctors who are being audited or who have issues with CMS. I'm not overstating that there are many experts in this field, but I have known John for 25 years and trust him completely. And as an aside, this is Chris Wolfe talking. I do not know John McGreal. I mean, all the things that I have read about him, he's got a lot of accolades. This is not a indictment of him either. So we'll get back to the letter. Why I'm telling you this. An area of concern that John raised at our meeting was that the Medicare, quote, audit-free years of COVID are gone. CMS has been ramping up their audit systems again, especially with their new coding systems they put in place last year. With the new E&M system in place, comparative billing reports are on the rise for all of us. You know what those are, but not all ODs do, since we are quite a bit under the CMS radar for Medicare and E&M coding audits. Particularly concerning are the use of CPT codes with modifiers, specifically co-management of cataract surgery. According to John, CMS is targeting cataract procedures and injections, intraocular and botulinum toxin, with a particular audit focus. Procedure codes and office visit codes with 24, 25, 52, 54, 55, and 79 modifiers are particular focus for Medicare audits. I bet a majority of your cataract co-management patients fall under this audit focus category. To me, that's a bit alarming as an OD and as someone who values our professional relationship with our mutual patients that we have worked together for many years. You've been such a great advocate for our patients who request and require co-management over the years. This audit news alarms me. Honestly, if I was an ophthalmologist co-managing my cataract patients with referring ODs, I'd change my systems in 2024 in light of this new audit guideline. With such a high audit risk on both ends of the co-management relationship, if I were a surgeon, I would work with referring ODs differently moving forward for the audit safety of both you and the OD. I have instructed our doctors and billing staff to change our billing systems moving forward. When we refer a patient to you for IOL, we will bill for the workup, consultation, and any other preliminary testing that was required, as we always have done, in anticipation of the patient's IOL. We will continue to bill Medicare appropriately using the new coding system. We will no longer, however, use any procedure modifiers to indicate joint care for the postoperative global period of the cataract patient during the 90-day global period that CMS associates with a typical cataract procedure. We will have you and your team assume all follow-up care for anything related to cataract surgery during the 90-day global period. We'll still see the patient for their final refraction, and they will be when they are released by you as being stable, but we will not assume any medical or financial risk during the 90-day postoperative period. We can, of course, still see those patients for any other issues they might have during the 90-day unrelated to the cataract procedure. Besides the legal concern of risking an audit for both you and us, I quite honestly doesn't make economic sense for us to bill using the 55 modifier during the 90-day period. Here's why. Right now, you are getting $511 for an uncomplicated cataract procedure per eye. CMS counts the 90-day global period as 20% of that fee, so the entire 90-day global care accounts for $102 and some cents out of that total fee. If we choose to maintain the current system in place where you release the patient who has requested co-management at day 21, we receive a potential maximum of $78 for the rest of the global period, specifically $78.36 for 69 days of possible care. That could be 2 visits or 10 visits depending on the patient's needs, i.e. $39 per visit down to $7.80 per visit. However, if we don't have to see that patient for 3 weeks following your release, then for that visit and all subsequent visits with the remaining 49-day period, we get paid a total of $56 for the remaining 49 days, regardless of how many times we see the patient. If we have to see the patient more than once during the remaining 69 days, for example, as stated above, now we're down to $39.18 for 2 visits. Heck, it takes more than $39.18 of staff time to get some of those patients into the exam room before we even see them. But here's the audit rub for the OD. Let's say the patient develops some floaters or any other CEIOL symptoms during the 90-day postoperative period. We all know that it's often a coincidence and not necessarily a byproduct of the CEIOL. Or is it, according to CMS? CMS is starting to look more closely for audit purposes at any procedure codes they receive for a CEIOL patient during the 90-day global period, especially if there's a 24, 54, 55, or 79 modifier associated with the same patient during the same period for the CPT code. That raises 2 red flags with CMS, one for you and one for us, and we don't like red flags. However, if that same patient who you are following for the entire 90-day global period has floaters and they decide to see me for the floaters, and I do not have anything to do with the 90-day global period, post-op period, is distinctly separate for me than it would be and than if I had assumed the follow-up care for the remaining 69 days. According to John, if we co-manage in the current format, CMS could easily make me financially responsible for the floaters visits since I assumed care and received my $78.36. But if I had nothing to do with the post-op care, i.e. the patient has no 55 modifier associated with them from me, then CMS is less likely to be concerned with me billing the 99214, 99201, and 92201 and 92202 for the same patient to evaluate their new symptoms. And if I felt the need to see them again in a month, the same thing applies, and I can bill separately for a second visit outside the CEIOL follow-up care as long as I'm not co-managing. If I am co-managing, then the visit and all visits related to the 90-day period, CMS would view as being covered by the $78 associated with the 55 modifier. Simply, for these economical reasons, why would I give up $160.19 or more for $78.36? And wouldn't I want your office to have the whole $102 post-op for the entire 90 days? You're already getting slammed on the reimbursement for CEIOL procedures. I think you should have the whole $511. Believe me, our doctors have plenty of ways to make more than $78.36 in our offices than plugging up our schedules with routine post-op global period CEIOL patients. You've been such a good advocate for unparalleled patient care, continuing education, and co-management with our patients who request it that I would hate to have you become the victim of an intense CMS audit for doing what has been the right thing for our patients. But we both know it's probably contrary to the mindset of the bean counting auditor looking over your and our records. I think historical and theoretical patient convenience for co-management at the patient's request during the global period, except under rare circumstances, does not outweigh the incredible financial risk and legal hassle that a third-tier level CMS audit would create for both surgeon and co-managing OD in the current CMS audit environment. Something to think about. Okay. Wow. I mean, I ultimately think that, again, it seems to me that fear in a lot of this has driven the potentiality of doing what's best for the patient. And again, I think that, optometrists who are afraid of audits and ophthalmologists who are afraid of audits can easily succumb to this reasoning and this line of thinking. And if you're looking at it purely from an economic stance, is this worth it to our practice to have to comply with specific audit guidelines or rules of being under an audit? Are the things that you have in place in your practice, the documentation that you have in place in your practice, are they going to protect you in an audit? I mean, those are unknowns for sure. They're unknowns, but they can be known. They are knowable. And you can put policies and procedure in your practice so that in the event of an audit, even if these audits are increasing, that when an auditor looks at your charts, it's very clear about what happened. In fact, that's what you should always be doing. If you're thinking about 99 codes and the new E&M guidelines, your chart should be very clear about what you did, and you shouldn't be afraid of audits. That's what we've preached at iCode for a number of years. Using audits as a reason not to do something, I think, is challenging in this case because we are abdicating our responsibility to the patient. The patient does want to come back in our office. They do want to ask you questions. And yeah, I mean, $78 is not a ton of money. I mean, that's one eye, but obviously you can consider both eyes during that post-operative period. And when you do that, I mean, even $78 is if you're taking over that patient's care at 1 week, but you might be taking over the care at 1 day. And so once that patient is released back to you, it may be a little bit more financially advantageous. There's also audits with modifiers during the global period. So if it is an unrelated problem that requires a E&M code during the postoperative period, there are legitimate modifiers, and those modifiers were mentioned. So rather than understanding when you're using those modifiers and how to document those modifiers, some people may decide that they're not going to use them at all because of risk of audit. I think that's the wrong behavior, right? Those modifiers exist for a specific reason. They allow us to communicate a specific reason that we're seeing a patient that might be different than normal. And in those cases, modifiers are completely appropriate. And even if you get audited and flagged, have a red flag because of one of those modifiers, it should just be distinctly clear about what you were doing and why you use that modifier in that specific situation. So let's get to the real issue, I think, in this case is, one, do we really believe as a profession that patients are best served, one, by convenience, coming back to the optometrist, and two, by that optometrist understanding all the nuances of their care? I mean, cataract surgeons are great. Anterior segment surgeons are great, but they haven't sat with the patient and thought about their ocular surface, their glaucoma, their macular degeneration. These are things that maybe they have documented in their preoperative and postoperative care, but they're not going to sit there and really work through those patients' problems. They don't have the time for it. They don't want to do it. And they're not the best place to do it for those patients. Our offices are. So if we own that, if we believe that, then it is our responsibility to take over that postoperative care. If we believe what our profession has been advocating for years, and I happen to, that we are the best place for those patients. And so they should be delivered back into our care, not just because of proximity reasons, but because they are best served in those cases. Now, the financial aspects are challenging. For sure, they're challenging. But again, very few patients should have to see you 10 times during the postoperative care. If they are, then maybe that's not the right cataract surgeon. If this is a regular thing, then maybe not the cataract surgeon isn't the right surgeon that the patient should be seeing. Maybe we should find other cataract surgeons to use. And I think we should be able to scrutinize those cataract surgeons, just like they can scrutinize us during the co-management period. It opens the door, it makes it more transparent, and we can know, hey, why did we do this? And why are we doing that? And we can ask questions and know why they may have taken different direction than perhaps we would have guided them within the IOL choice, for example. So I think first, when I reflect on this, I don't see any reference to a, quote, new system that was mentioned all over the place in terms of CMS audits. CMS will audit us. We shouldn't have to worry about audits because we've documented appropriately. I've already talked about that. It seems that what's being described isn't really a new system, but rather an intensified focus on enforcing existing rules, particularly with premium IOL co-management rather than just straight co-management. So let's say that they're looking for 54 and 55 modifiers as the place to start. And then they're going to look outside of that to see, was there a premium IOL co-management that was separated appropriately? Was it done appropriately, or was it done inappropriately? That's probably what they're looking for. And that's probably what Dr. McGrill was referencing. Again, I wasn't at that talk, but that's my assumption based on what is illegal and what isn't appropriate within the Stark Law. Now, again, there are clear ways to do that. We're going to talk about that in just a second. But the laws governing co-management have not changed. They've just haven't been rigidly enforced related to premium IOL until recently. And this recent whistleblower actions through our colleagues, and basically our colleague, Dr. Joe Deloche, has helped a lot of practices through this. But recently, with those whistleblowers' actions, have likely reignited that federal attention and compliance, and undoubtedly need to have more meticulous documentation moving forward. It's worth emphasizing that audits targeting the use of things like 24, 54, 55 modifiers, etc., don't make co-management inherently inappropriate. They simply require that co-management, especially for premium IOLs, be conducted correctly with proper documentation and adherence to long-standing, these are not new, long-standing requirements that mitigate much of the perceived risk. Okay, so for legal co-management, the following principles should be followed. The patient has a written agreement. Patients are explicitly consenting to co-management in writing. There needs to be written transfer of care. There must be a documentation of transfer of care between the referring optometrist, then the ophthalmologist, then back to the referring optometrist. There needs to be, in the case of, just look at it just like your co-management fee. When you bill co-management, you're going to bill, the surgeon's going to bill for the surgical package. You're going to bill for the co-management package, and the surgeon's going to get paid from CMS or other payers for the surgical package. You are going to get paid for the co-management package. It is completely separate. You do the same thing on premium IOLs. There are separate fees. Each physician sets their own fees. I set my fees. I tell the surgeon what those fees are. I collect my own fees, and the surgeon collects their own fees. Now, there are independent. So again, you're independently correcting your own fees. So each provider is responsible for setting the fees and for collecting the fees of the co-management, specifically with PCI or premium IOLs. These requirements apply universally, whether they're for standard IOLs or premium IOLs. And there are programs like COFI, which is not an endorsement of them, but COFI, that allow a structured legal solution for co-managing premium IOLs while maintaining compliance with federal regulations. And so I think the bottom line is, while Dr. Faith's concerns about audit risks are valid, just in general, they're valid, right? You have to think about audits, and there are ways to document and protect against them. The thrust of this argument seems more focused on the economics of co-management. And while it's true that co-management may not always make immediate financial sense for the optometrist, the decision should prioritize what is in the best interest of the patient. Additionally, there are often confounding issues like glaucoma, dry eye, where the optometrist is already managing those conditions, is better suited to address related or unrelated complications during that postoperative period. Co-management remains valuable and ethical approach to patient care, especially when patient convenience, continuity of care, and access to care are at stake. The focus should be on ensuring compliance, not abandoning the practice altogether. With the right processes and systems in place, optometrists and ophthalmologists can continue to provide high-quality, patient-centered care while minimizing risks and protecting all parties involved. I hope this monologue was helpful to you. I hope I brought up a few issues that you may or may not have thought about, and we'd love to think more about them. If you're looking for help with compliance, PCS is your place. That PCS did not sponsor this podcast, but they do a great job. If you want insight in terms of how to navigate this in a way that can work for your practice, that's what we do at iCode Education. We'd love to work with you more. I hope this was helpful. And again, I'll see you guys on the next one.
Hey, if you enjoyed this episode, make sure to subscribe to us on Apple Podcasts and our YouTube channel, both linked in the show notes. Now, here's something exciting. We're giving away a 1-year subscription to Comprehensive Optometry Simplified. All you have to do is leave us a review on Apple Podcasts, take a screenshot, and email it to me at questions@icodeeducation.com. We'll put that in the show notes as well. We'll be selecting a winner on December 15th, so don't miss your chance to get access to this valuable resource. Thanks again for listening. I can't wait to see your reviews.